Welcome to the deep dive. Today, we're taking a close look at hyperbaric oxygen therapy, HBOT, and its really intriguing role in treating various eye conditions.
Right.
We've sifted through quite a bit of research, clinical findings, trying to pull out the key stuff for you.
Yeah, and if you're someone who's, ever worried about vision loss, or maybe you're just fascinated by these sort of cutting-edge treatments, this should be really interesting.
Definitely.
We're basically talking about using pure oxygen in a pressurized room and how that might, well, potentially revolutionize how we treat a whole range of eye problems.
Exactly. So our mission today is really to get to the heart of what HBOT actually does to your eyes. What's the science saying? Is it effective? And, for which conditions?
And we're grounding this in a pretty detailed review. It covers how oxygen affects the eye, what the existing literature says about HBOT for eye issues, and also, importantly, the potential downsides or complications.
Right. This isn't just theory. It's based on, well, years of research and actual clinical experience. We want to give you a clear picture, the potential benefits, the limitations, and where it really seems to show promise.
Okay, so maybe we should start with the basics. Just real quick, how vision works, because that helps understand everything else.
Good idea.
Ah.
Lay the foundation.
So light enters your eye, right? Goes through the cornea, the pupil, then the lens focuses it.
Through that jelly stuff, the vitreous body.
Exactly, through the vitreous gel onto the retina, which is lining the back of the eye.
And the retina, that's the really critical part for actually seeing.
That's where the magic happens, yeah.
Right.
It converts the light into electrical signals.
Signals that then travel up the optic nerve to the brain.
And the brain interprets those signals as, the world you see around you.
Okay, so the retina needs fuel, needs oxygen like crazy, I imagine.
It absolutely does. It's very metabolically active. And what's really fascinating is its blood supply. It actually has two sources. Yeah, the inner layers get blood from the retinal circulation, tiny vessels within the retina itself. But the outer layers, including the photoreceptors, they get their oxygen mostly from the choroidal circulation.
Choroidal.
Yeah.
That's a network behind the retina.
Precisely. A very rich network of blood vessels. And under normal circumstances, this choroid supplies a huge amount of the retina's oxygen.
Okay, so that dual supply is key. Now, how does HBOT play into this? You mentioned high oxygen levels.
Right. So here's the really interesting bit. Research shows that when you significantly increase the oxygen level in the blood, like you do with HBOT, that choroidal circulation, the one behind the retina,
Yeah.
it might actually be able to supply enough oxygen for the entire retina, even if the regular retinal blood flow, that inner supply, is blocked or compromised.
Wow, okay, so the backup system can potentially take over completely.
That's the potential, yes. It's a critical concept for understanding how HBOT could help in certain conditions.
And you mentioned something about a specific artery, cilio something.
Yes, the cilioretinal artery. Some people, not everyone, have this extra artery branching off, and it often goes straight to the macula.
The macula being the center for sharp vision.
Exactly. So if the main retinal artery gets blocked, but you have a functioning cilioretinal artery, your central vision might actually be spared. It's a bit of anatomical luck.
Okay, fascinating. So HBOT floods the system with oxygen. What does that actually do to the oxygen levels inside the different parts of the eye under that pressure?
Well, studies have looked at this. Oxygen tension, the sort of pressure or concentration of oxygen, it tends to be higher in the vitreous humor, that gel filling the eye, than in the anterior chamber, the fluid space at the front.
Yeah.
But what's really notable is how the eye responds compared to other tissues. When you breathe pure oxygen, the relative increase in oxygen within the eye's fluids is actually greater than what you see in, say, muscle tissue.
Huh. So the eye is particularly responsive to this extra oxygen.
It seems that way, which might explain why it seems particularly sensitive to both the good effects and, potentially, the bad effects of high oxygen levels.
And this links back to the idea that the choroid could take over if the retinal artery is blocked.
Exactly. That surge of oxygen provided by HBOT, delivered through the choroid, might be enough to keep the retina alive even when its primary blood supply is cut off.
Which leads us to what HBOT does to the blood vessels themselves in the eye. You hear about vasoconstriction.
Yes. That's a well-documented effect. Under hyperbaric oxygen, the retinal blood vessels tend to narrow, they constrict.
Which sounds bad, right? If the vessels narrow, wouldn't that mean less oxygen gets through?
That was the initial thought, logically. You'd assume less flow means less oxygen deliveries.
Right.
But interestingly, studies looking at the oxygen saturation in the blood leaving the retina in the retinal veins found that saturation actually increases during HBOT.
Increases. even with narrower arteries. How does that work?
It tells us that the choroid, flooded with highly oxygenated blood, is doing such an efficient job of supplying oxygen from behind that it more than makes up for any reduced flow from the constricted retinal arteries.
So the backup system is really powerful under HBOT.
It appears so. And some animal studies even measured oxygen levels right in front of the retina, near the inner layers, and found those levels increase too during HBOT. So oxygen is getting there. It's a fascinating adaptation.
That really is surprising. So better oxygenation despite narrower pipes. What about eye pressure, intraocular pressure, or IOP? Does HBOT affect that?
Also interesting, some research suggests that hyperoxia, high oxygen levels, might actually lead to a decrease in IOP.
A decrease? Why would that happen?
The exact mechanism isn't totally clear. One theory is that the vasoconstriction we just talked about might play a role, maybe reducing fluid production slightly.
Okay.
But it's important to remember, if you're measuring IOP inside a hyperbaric chamber, the reading is relative to the higher pressure outside the eye in the chamber itself.
Ah, right. Good point. Okay, so lots of potential benefits, but we have to talk about the risks. Oxygen toxicity. Can too much oxygen be bad for the eyes?
Absolutely, that's a critical consideration. Oxygen can be toxic to eye tissues, especially at very high pressures or with really prolonged exposure.
But for typical HBOT treatments?
For the pressures usually used in clinical HBOT for adults, say, around 2 to 2.5 times normal atmospheric pressure, ATA. Significant eye toxicity isn't usually the primary limiting factor. Often, potential lung issues might arise before major eye problems at those levels in adults.
So people have noticed some effects, right? Like changes in vision.
Yes. Even back in the 1930s, researchers noted that breathing oxygen at 3 ATA for a few hours could cause a temporary decrease in peripheral or side vision.
Temporary, though.
Yes, temporary and reversible. It went away completely once they returned to breathing normal air. There was also a temporary dip in the electroretinogram, the ERG, which measures retinal electrical activity.
But sharpness of vision was okay.
Visual acuity, yeah, and how the brain processed the visual information, that seemed to remain normal in those early studies.
Okay. Now, this is very different from the big concern with premature babies. Retinopathy of prematurity, right?
Right.
That's also linked to oxygen.
Absolutely different context, and critically important to distinguish. High levels of supplemental oxygen are definitely toxic to the immature, developing retina of premature infants. It disrupts normal blood vessel growth and can tragically lead to blindness.
A major issue in neonatal care.
Huge. But what's quite interesting, almost paradoxical, is a study done in newborn rats. They found that giving them HBOT actually seemed to have a protective effect against the kind of retinopathy caused by high oxygen at normal pressure.
Protective. That is strange.
It really highlights how complex the eye's response to oxygen is and how it depends on maturity and the specific conditions.
Okay. What about effects on the lens? Any long-term issues there with HBOT? I think I've heard about vision shifts.
Yes. Two main things regarding the lens. First, there's temporary nearsightedness, what's called hyperoxic myopia.
Myopia, meaning nearsightedness.
Correct. This has been seen in divers and HBOT patients, sometimes even at lower pressures. It's usually temporary, though. It typically resolves within weeks, maybe months after the HBOT course is finished.
Okay. Temporary is manageable. What's the other concern?
The more significant one is the potential for cataracts, the clouding of the lens, especially with very long courses of treatment.
How long are we talking?
We're generally talking about patients undergoing daily HBOT for many, many sessions, often 150 or more, typically at pressures around 2.0 to 2.5 ATA.
And is there a warning sign?
Well, interestingly, many of these patients who developed cataracts also experienced that temporary myopia during the treatment course. Some researchers think that myopic shift might be an early warning sign of changes happening in the lens nucleus that could lead to a cataract later.
But if it does happen?
While the lens changes might not completely reverse, the good news is that modern cataract surgery is incredibly effective. So, if the medical reason for needing that much HBOT is strong, the potential for cataracts is often considered a manageable complication.
Okay, good to know. So we've covered potential risks. Now, are there times when HBOT is definitely not the right choice for an eye problem? Specific contraindications?
Yes, absolutely. There are a few key ones. The most critical is if someone has an intraocular gas bubble inside their eye.
From a recent eye surgery, maybe?
Exactly. Often used in retinal detachment repair or similar procedures. Gas expands when pressure decreases and contracts when pressure increases, Boyle's law.
Right.
So putting someone with a gas bubble in a hyperbaric chamber where pressure increases, and then especially during decompression when pressure drops.
That sounds dangerous.
It can be. It can cause barotrauma, pressure injury inside the eye, or even block the central retinal artery during the decompression phase. It's why people are warned about flying too soon after certain eye surgeries too, similar pressure changes.
Makes perfect sense.
Yep.
A trapped gas bubble and changing pressure is a bad mix. Any others?
Well, hollow orbital prostheses, artificial eyes that are actually hollow inside, are considered a relative contraindication,
Religa.
meaning it's a maybe. There's a potential risk they could collapse under pressure, even at relatively shallow depths. But honestly, most modern ocular implants are solid, so this isn't usually an issue.
Okay.
And there's an important exception regarding those gas bubbles we mentioned.
Oh.
If the gas bubble itself is because of decompression sickness affecting the eye, or due to gas gangrene in the eye, well, HBOT is the primary treatment for those conditions anyway.
Ah, so you treat the underlying cause even with the bubble present.
Right. In those specific rare cases, the body's natural fluid volumes help buffer the pressure changes somewhat, and the need for HBOT outweighs the risk from the bubble itself.
Okay, got it.
Yeah.
Before someone starts HBOT for an eye emergency, say, is there any quick check that needs to happen first?
Yes, especially in emergencies like a sudden central retinal artery occlusion, that eye stroke we mentioned, or an arterial gas embolism that's causing vision loss. Time is absolutely critical.
You don't want to delay treatment for lots of tests.
Exactly. Delaying HBOT for extensive eye exams could make the outcome much worse. However, a very quick check of basic visual function is important.
Like reading an eye chart.
Yeah, using an emergency department eye chart, maybe checking color vision plates if they're available. Just something quick to get a baseline measurement before treatment starts and to see if there's any change during the HBOT session.
And then a full exam later.
Absolutely.
Yeah.
A comprehensive eye exam by an ophthalmologist should happen as soon as it's practical after that first emergency HBOT treatment.
Okay. Let's get to the main event then. When is HBOT strongly recommended? Where's the solid evidence for using it in eye conditions?
All right. The conditions where the evidence is strongest, where it's generally considered a recommended therapy, include several categories. First, as we touched upon, decompression sickness or arterial gas embolism that causes visual symptoms. That's a definite yes.
Okay.
Second, really severe infections like ocular or orbital gas gangrene or other necrotizing flesh-eating type infections, including some fungal infections involving the eye socket. HBOT is often used as an adjunct alongside antibiotics and surgery.
Makes sense for severe infections. What else?
Carbon monoxide poisoning that results in visual problems is another accepted indication. Also, radiation optic neuropathy.
That's damage from radiation therapy.
Yes, a delayed side effect where radiation damages the blood vessel supplying the optic nerve. And then there's a category related to healing issues, things like compromised skin grafts or flaps around the eye, including conjunctival grafts.
Like after surgery or injury.
Exactly. Or scleral ischemia or necrosis, where the white part of the eye isn't getting enough blood, maybe after certain treatments. And also, interestingly, recurrent pterygium.
Pterygium. That's that growth on the eye surface. Recurrent means it keeps coming back after surgery.
Precisely. HBOT might help grafts take better or reduce inflammation in those cases.
Okay, that's a solid list. Let's focus on central retinal artery occlusion, CRAO, for a minute. You said it's like a stroke of the eye.
It really is. It typically presents as sudden, completely painless loss of vision in one eye. It can range from just dimming to total blindness.
The doctor looks inside.
The retina often looks pale, sometimes described as milky because of the lack of blood flow. And often you see this classic cherry red spot right in the center at the fovea.
Why cherry red?
Because the fovea itself is very thin and gets some underlying oxygen supply from the choroid, so its normal red color stands out against the pale, oxygen-starved surrounding retina.
And the outcome without treatment is usually bad.
Generally very poor, unfortunately. The retina has an incredibly high demand for oxygen, so it's extremely vulnerable to ischemia, that lack of blood flow. Permanent damage happens fast.
So how exactly does HBOT help in CRAO? What's the goal?
The main goal is simple. Deliver enough oxygen to keep the retinal cells alive, specifically the inner retinal layers, which rely on that blocked artery. HBOT forces oxygen into the plasma and surrounding tissues, allowing it to reach the retina via diffusion from the choroid, bypassing the blockage.
Buying time, essentially.
Exactly. Buying time to maintain the retina's viability until, hopefully, blood flow in the artery can be restored, either spontaneously or through other interventions.
And animal studies support this.
Yes, animal models of CRAO have shown that HBOT can significantly reduce the amount of retinal cell death, the apoptosis, that occurs after the artery is blocked.
And the key is timing, you said. How quickly does it need to happen?
As quickly as humanly possible. Ideally within the first few hours of vision loss, the data suggests the best chance for significant recovery is within maybe 8 hours, although some benefit has been seen up to 24 hours. And there are even anecdotal reports of improvement when started later. But sooner is always better.
Time is vision.
Absolutely. Every minute counts.
And does this actually work in people? Because you hear that standard treatments for CRAO often don't do much.
That's true. Traditional treatments have often been disappointing. But there are quite a few compelling case reports and some retrospective studies showing significant visual improvement in CRAO patients treated with HBOT.
Better than standard care.
Yes, particularly when initiated early. There are cases where patients literally started regaining vision while they were being compressed in the HBOT chamber. That's pretty dramatic.
Wow.
And one study specifically showed a much higher rate of meaningful visual recovery in patients getting HBOT within 8 hours compared to a control group getting standard care. It suggests HBOT can make a real difference when used promptly.
That's very encouraging, especially for such a devastating condition. Okay, what about conditions where the evidence is maybe promising, but not quite as definitive as CRAO, the potential uses?
Right. This category covers several interesting areas where HBOT shows potential, but maybe needs more large-scale studies. One is postoperative anterior segment ischemia.
Ischemia at the front of the eye.
Yes, it's a rare complication sometimes seen after complex eye muscle surgery, like for correcting crossed eyes. HBOT might help by boosting oxygen levels in the anterior chamber fluid.
Makes sense. What else?
Ischemic optic neuropathy, often called NAION for the non-arteritic type. This is another cause of sudden vision loss, usually in older adults, affecting the optic nerve head.
And the thinking for HBOT here.
The optic nerve head gets some blood supply from branches related to the choroidal circulation, so the idea is that HBOT might enhance oxygen delivery there too. Some case series have reported good results, even when started weeks after onset, but other studies haven't found a clear benefit, so it's still debated.
Okay, mixed results there.
Then there's ischemic central retinal vein occlusion, CRVO. Here, the main vein draining the retina gets blocked, not the artery supplying it.
So blood can't get out easily.
Right, leading to swelling, bleeding, and lack of oxygen in the retina. The ischemic type is more severe and carries a high risk of complications like neovascular glaucoma. HBOT aims to keep the retina viable while the body tries to clear the blockage. There are some remarkable case reports of vision recovery here too.
Interesting. So artery blockages, vein blockages, optic nerve issues.
Mm-hmm.
What else is in this promising group?
Branch retinal artery occlusion, or BRAO, that's where just a smaller branch of the retinal artery gets blocked. If it doesn't affect the central macula, the person might not even notice it.
What if it does hit the center?
Then it can cause significant central vision loss. In those severe cases, HBOT might have a role. There's at least one case report showing improvement when HBOT was added to other treatments.
Okay. How about swelling? Macular edema.
Yes, cystoid macular edema, or CME, that's fluid buildup in the macula, making central vision blurry. It can happen after vein occlusions, after eye surgery, or with inflammatory conditions like uveitis.
And HBOT helps with the swelling.
Several studies, particularly for CME related to retinal vein occlusions, have shown pretty rapid visual improvement with HBOT. The thinking is the vasoconstriction might reduce leakage, and maybe it also affects inflammatory factors like VEGF.
VEGS, that's involved in diabetic eye disease too, right?
Yes, vascular endothelial growth factor. It promotes leaky blood vessels, so reducing it could definitely help with edema. There are also reports of HBOT helping CME after surgery, and some mixed results for uveitis-related CME.
Okay. Any infections in this group?
Yes, refractory Pseudomonas keratitis. Pseudomonas is a nasty bacteria that can cause severe corneal infections, ulcers. Refractory means it's not responding well to standard powerful antibiotics.
And HBOT helped.
There's a really compelling case report where adding HBOT to the antibiotics led to rapid clearing of the infection and visual improvement in a very severe case.
Wow. One more in this category.
Pyoderma gangrenosum. It's a rare, nasty, ulcerative skin condition, and sometimes it can affect the orbit, the eye socket area. In one severe, progressive case involving the orbit, HBOT was considered a really valuable addition to the other treatments trying to control it.
That's quite a range of conditions where it seems promising, even if more research is needed for some. Now, what about things with even less evidence but still worth mentioning? The other reported uses.
Yeah, this is where the evidence might be more anecdotal or based on smaller studies, but still intriguing. One is toxic amblyopia.
Vision loss from poisons.
Exactly, like from ingesting quinine, which used to be used for malaria and leg cramps. There's a dramatic report of 2 patients with severe quinine poisoning, nearly blind, who had almost complete vision restoration after HBOT.
That's incredible.
Another is retinitis pigmentosa, RP. This is a group of genetic disorders causing progressive loss of photoreceptor cells.
A degenerative condition.
Right. Some older, smaller studies suggested HBOT might slow the progression or improve ERG readings, but there's also a theoretical concern about increasing oxidative stress in an already stressed retina, so it's not widely used or recommended currently.
Needs caution.
Then, visual field defects after macular hole surgery. One study reported significant recovery of side vision lost after this type of surgery when patients received HBOT.
Interesting post-surgical application. What about diabetes? Diabetic retinopathy is a huge problem.
It is a leading cause of blindness. There's some thought HBOT might help in early stages by reducing macular edema and ischemia. A few case reports show visual improvement or reduced macular thickness.
What?
But it's a chronic, lifelong disease. HBOT is typically given in courses, so the challenge is how you'd apply it long-term. It's not a standard treatment.
Right, practicalities are tough there.
Uveitis, that internal eye inflammation, showed some positive effects in a rabbit study, suggesting HBOT might boost the effectiveness of steroids. Secondary keratoendotheliosis, a problem with the cornea's inner lining, showed improved vision with HBOT in one study.
Okay.
Sickle cell disease complications. Sometimes patients develop retinal detachments or bleeding in the eye, hyphema. Interestingly, using hyperbaric conditions during retinal detachment surgery in sickle cell patients seem to prevent complications, and HBOT itself has been proposed for treating hyphema in these patients.
Using a pressure environment strategically.
Exactly. And finally, glaucoma. The theory is that ischemia, poor blood flow, might contribute to optic nerve damage in glaucoma. One double-blind study actually reported an improvement in visual fields in glaucoma patients treated with HBOT compared to a control group.
Really? Glaucoma. That's a potential game changer if true.
It is, but again, needs much more research before becoming mainstream. It's an intriguing finding, though.
Definitely. Okay, so we've covered a lot of ground. You mentioned the urgency for things like CRAO. Is there a sort of ideal emergency protocol if someone shows up with sudden vision loss?
Based on the potential benefit of rapid HBOT for several causes of acute, painless vision loss, yeah, there's a proposed kind of pathway. First, immediate triage. Anyone with sudden, painless loss needs urgent attention.
Step 1, recognize the emergency.
Right. Then, a quick vision check. If it's significantly down and doesn't get better when they look through a pinhole.
Pinhole helps rule out simple refractive errors.
Exactly. And if the patient fits the profile, maybe older, sudden onset, no flashes or floaters suggesting retinal detachment, then you have to strongly consider a vascular occlusion like CRAO and think about emergent HBOT.
Alongside getting an eye doctor involved ASAP.
Absolutely. Ophthalmology consult is crucial. But while waiting, or if transport is needed, start supplemental oxygen immediately. High flow. Highest concentration available.
Just regular oxygen.
Yes, normobaric oxygen first. If, remarkably, their vision starts improving rapidly just with that, maybe they get admitted for observation and continued oxygen. If there's no quick improvement,
And HBOT?
then emergent HBOT should be strongly considered and initiated as fast as possible. The protocols often involve starting at a certain pressure, monitoring vision inside the chamber if possible, and potentially increasing pressure if there's no response, following established safety guidelines, of course.
And follow-up is key, too.
Crucial. Close monitoring by a retinal specialist is needed, as sometimes vision can fluctuate or relapse even after initial improvement.
Wow. This has been incredibly thorough. So just to wrap up the main points, HBOT really does show significant promise, doesn't it? Especially for eye conditions where blood flow, oxygen supply, infection, or healing are the core problems.
Absolutely. And the theme that keeps coming up is timing, especially for those acute blockages like CRAO. Getting treatment quickly seems to make a world of difference.
It really does.
And what's really interesting is thinking about how HBOT is still considered somewhat specialized, maybe even alternative by some for eye conditions, but the evidence base is growing.
Right. It suggests it could become a much more standard tool in the ophthalmologist's toolkit down the line.
Exactly. Which leads to a thought, maybe for you listening. HBOT is one example. What other therapies, maybe things currently considered unconventional or on the fringes, might actually hold untapped potential for helping us preserve something as vital as our sight?
That's a really provocative question to end on. And a practical takeaway, if you or someone you know is dealing with vision loss, especially some of the conditions we discussed,
Yeah.
it might be worth bringing this information up with your ophthalmologist.
Particularly one who might be familiar with hyperbaric medicine or open to exploring all options. It could open doors.
Definitely food for thought. Thank you so much for sharing all this today.
My pleasure.
And thank you for joining us for this deep dive.